I just sent a mass email with the ID to those that have registered.
Okay. Nope.
Hey, Paula. Hello, everyone. Welcome. We're excited to have you here on this special edition of Hope Zoom with our very special guest, Dr. Jula Veerapong.
I got volume in here.
Pardon? As other people are joining, we'll go ahead and do some introductions. And so, we are so thrilled that some of you are new to our Hope Zoom. And so we'll talk a little bit about PMP PALS first, and then Dr. Veerapong will get right into his presentation. So my name's Adele Jason. I'm a patient, I'm a volunteer, and I'm the president of our PALS board. Charmaine.
Hi, everybody. I'm also a patient. I'm also on the board and a volunteer, and was diagnosed in 1997. So been in this arena for a long time.
Connie.
Hi, everyone. Good morning. I am a caregiver, mentor, volunteer, and my husband was diagnosed in 2015.
Jamie.
Hi, everybody. I'm Jamie. I was diagnosed with goblet cell in 2019, and I am a volunteer and mentor here. Welcome.
James.
Hi everyone, James Caldwell from Northern Ireland. I was diagnosed with high-grade appendix cancer in 2014, and I'm a volunteer. Good to see everyone.
Roberta.
Good morning. From California, I am a patient and I was diagnosed in 2022, and I'm also a volunteer and a patient mentor. Welcome.
Lindsay.
Hi, everyone. I'm Lindsay. Excuse me. I was diagnosed with lamin at the end of 2021. And I am also a mentor, Hope Zoom host, and co-chair of the PALS meetup with Roberta. Nice to meet everyone.
And I'm going to let our special guest, Dr. Veerapong, give a brief intro. I have a lengthy bio, but you maybe don't want me to read all of it. But Dr. Veerapong is, one of our most experienced specialists, huge supporter of PALS, and he's out at UCSD. But Dr. Veerapong.
Hi, guys. Thank you for having me. Yes, I'm Jula Veerapong out here at UC San Diego. I'm, as you're aware, a surgical oncologist, and I've been in practice for, gosh, like a decade and a half now. And it's very interesting because my very first job out of fellowship, who would have thought that my very first case would be a HIPEC? And so, I ended up developing a very peritoneal surface malignancy based practice in St. Louis. And then Dr. Lowy, whom many of you know, recruited me to join him and Dr. Baumgartner. And then at that time, Dr. Kelly, who's now at the University of Wisconsin, to help with the HIPEC program. And here I am.
Well, thank you for being here today, and we're looking forward to your presentation. Before we get to that, as I mentioned, since some of you are new, we'd like to take an opportunity to tell you a little bit more about PALS. So I am going to share my screen. Can everyone see that?
Yes.
Okay, so just a few comments. So PMP PALS is the world's oldest global volunteer-run organization, giving hope to patients and caregivers with an appendix cancer diagnosis and related conditions like PMP. And I always have trouble with advancing this. Just some disclaimers with regard to Hope Zoom. We provide these forums for fellowship and support. We're not licensed to provide medical advice, so patients must seek your own licensed physicians qualified to develop your own individual treatment plans. We do have a guest presentation today, and just sometimes images or data might be a little scary to patients, but just remember each situation is different. By participating in this forum, that means your identity and health condition may be shared. You could change your name, mute your video, mute or cancel your audio. And by participating, you give us permission to share your image on these videos. We do record this, and this is one that we will put on our website because of the presentation. Just some programs that we have. Hope Zoom, our veterans know that, we faithfully meet twice a week to, provide fellowship and support and information. As part of our programming, we have various physician presentations, today with Dr. Veerapong's presentation being one of them. Our Bare Bottom Bears program is one of our oldest programs, and these are just a token of encouragement and a reminder of the hope we have for everybody, whether you're preparing for surgery or in any other situation. Same with our card program. We send, cards out, letting folks know we're thinking of you. We're on social media. We do provide group mentoring through these Zoom calls, but we have individual one-on-one support. Broad blankets, that was Lindsay and Lindsay's father. So we send blankets to those patients, similar to sending out the bears. And then just living life. We're here to help people navigate their individual journeys and talk about how we live life in terms of dealing with this disease. You can reach us at info@pmpals.net or our website, pmpals.net. We are entirely volunteer driven and donation run. And we'll talk a little bit more about that at the end. And our mantra has always been, we have hope for you. So we have hope for all of you, and glad you are here.
Adele,
yes.
Do you mind if I just interject a couple of things about
go ahead.
The origin of our Hope Zoom was during the pandemic. It was a couple months after the pandemic started that we saw people using Zoom in all kinds of ways for family meetings, work, everything. So it opened up this opportunity for us where people had a tool that was very easy to use. It was much, much easier to use than anything that had really been available on a mass basis around the world. So it opened up this new opportunity. So we began Hope Zoom 5 years ago, late April, early May. Dr. Veerapong was our first surgeon guest on the show. We call it show, meeting, call, a different terminology. But I just wanted to point out some of our social media posts this week had some of our statistics. We've done over 400 meetings since then. We started out doing one meeting per week for about a year, but then it grew in popularity and we couldn't really get to everybody in a reasonable amount of time on Saturday morning. So we added our Wednesday meeting. So we've had over 400 meetings. We've had over 40 surgeon presentations during that time period. We've had over 6,000 people register and attend the meetings over that 5-year period. And I want to just give a shout out to the volunteers too. We do have usually at least 2 and sometimes more co-hosts on the show. It really expands the base of knowledge and provides some continuity. We've put in over 2,000 hours of volunteer time over the last 5 years, supporting the show, producing it, hosting, and sharing our time and our own experiences. So we're really proud of what we've done here. And I just, for those of y'all who really kind of wonder how did all this get started, it does go back to the pandemic, but it was a great idea. It's been one of our most successful programs in reaching people. So it's a permanent fixture now.
It is, and we learned so much from each other, and we're excited to have this 5-year milestone. And so with that, Dr. Veerapong, we're going to turn it over to you.
Thank you. Well, it is certainly an honor and a privilege to always join you and all the attendees in the HOPE Zoom. I'm going to go ahead and share my screen, and thank you for inviting me. Hope can everyone see that?
Yeah.
And then FYI, I see people trickling in. Oh, they're Elena, so I'll admit. So I've been kind of clicking them as they come in, but maybe if you guys see attendees come in.
I can handle, don't worry, but I could admit people, so you can
All right.
focus on the presentation. I've got it. Thank you.
So, I know that there are some questions. Charmaine, thank you for sending those questions. I want to be able to address those so I can, I don't want to go too fast. This is kind of information dense, but we can kind of get an overview. Essentially, we'll be talking about rehabilitation and rehab with a focus on exercise. But on top of that, I'd like to talk about the value of nutrition and the value of anxiety and stress reduction. So we'll talk about the stress of cytoreductive surgery and HIPEC. You know firsthand more than I, in the front lines of the stress of this type of procedure. Goals of rehabilitation. We'll talk about enhanced recovery after surgery, also called ERAS. Talk about prehabilitation and the difference between prehabilitation and rehabilitation, and then we'll summarize. So in terms of the stress of cytoreductive surgery, it's it's called the mother of all surgery. It's a life-saving, but it's a high-stress treatment. Super aggressive. As you're aware, the cytoreduction removes all gross visible disease. At least that's the goal. The heated chemo delivers chemotherapy, a cytotoxic agent, directly into the abdomen. And there are survival benefits, but it's really a high toll in terms of physiologic, nutritional, and emotional stress. So in terms of the physiologic stress response, cytoreductive surgery can exceed 6 hours. I would say 6 hours is kind of on the lower end, if you will. I've had HIPECs go maybe 4 hours. I've had HIPECs go 20 hours. Nowadays, my average is probably around 6 to 8 hours. But because it involves chemotherapy and because it involves heat at 41 to 43 degrees centigrade, with your normal body temperature being just under 38, you can have some physiologic consequences like a systemic inflammatory response. You can have capillary leak, third spacing. You can have transient organ dysfunction, as you see on the diagram to the right, that can affect the urinary system. Some of these agents we use are nephrotoxic, toxic to the kidney. It certainly causes an ileus. It can cause a neutropenia, where you have your white count be critically low so that you can't fight infection. And it can also cause derangement in terms of your metabolic system. A lot of times with these procedures, you need ICU level of care, at least in the post-op day 0. At UC San Diego, we have this unit called the Rapid Recovery Unit, which is designed for post-op patients, and it can function anywhere from intermediate to ICU level of care. So there can be physiologic consequences, like, as mentioned, cardiovascular and hemodynamic effects. And part of this is due to the surgery. Part of it's due to fluid loss. Part of it is due to hypothermia. And part of it is due to, some of you may have epidurals and you're getting narcotics that causes the blood pressure to go down. You can have a metabolic response where you have increased oxygen demand and potential renal dysfunction. And then this can lend itself to potential complications such as ileus and kind of the thing that we fear about the most, leaks of the connections between the bowel and fistulas. In terms of nutritional stress and malnutrition, the surgery and the HIPEC disrupts gastrointestinal function and metabolic balance. Main postoperative issues are delayed to return of bowel function. So anytime you open up the abdomen, anytime you manipulate the abdomen, the bowels hibernate. Now you're adding heat and now you're adding chemotherapy and they hibernate even longer. And so I posit that, the reason why most of you are in the hospital so long is really because your hospital length of stay is dictated by whether your bowels start working. So in order for my patients to go home, they have to be eating, pooping, ideally, eating, pooping, walking, having controlled pain, and urinating okay. So the key nutritional issues is that you have a hypermetabolic state and therefore a catabolic state. So a lot of you, I'm sure, have experienced in the first 2 months after surgery, kind of this profound weight loss that you can't even control. And a lot of my patients say that they don't have an appetite or things taste bland or things taste metallic. So there's a high risk of protein energy malnutrition. And so I'm sure several of you or many of you have required either some kind of supplementation, either enterally or through the IV. And the thing about the challenges associated with nutrition and cytoreductive surgery and HIPEC is that, a lot of patients, a lot of you have poor nutritional status even before surgery because you have this fluid buildup, or if in the case of pseudomyxoma, PMP, you have this, colloquially, a jelly belly that pushes up against your stomach, pushes up against your diaphragm, and so your nutrition is not optimized. We utilize a malnutrition screen to try to screen patients, but most of the times, a registered dietitian is necessary preoperatively. In terms of post-op, again, as noted, sometimes you need some kind of nutritional support, whether that's, in the form of a supplement like Boost or Ensure or Kate's Farm, or sometimes, in the case of a prolonged ileus where your bowels are sleepy, you may need TPN. In terms of psychosocial and emotional stressors, I see it in a lot of my patients, and caregivers. The stress is high. The recovery is long, and a lot of times it's like watching paint dry. You're thinking, when am I going to get better? And sometimes it takes 3 to 6 months before you start feeling your baseline. One of the more one of the articles that really looks at it is from the Wake Forest group, where they looked at quality of life, and in their study they show that it takes up to 6 months to kind of get back to your normal baseline. A lot of anxiety and depression and adjustment orders can be associated with just having the diagnosis. And, even if you're kind of, a normally functional person, having the stress of just, going to, well, for example, if I have a patient from Hawaii who comes in and visits me and has their surgery here, they're in the hospital for, a week to 2 weeks, and then they have to stay in town for another week. It takes an emotional and a physiologic toll. So things that we try to make sure that is on board for our patients is psychosocial help and the palliative care service, which we have, we call it the HOWL service or the symptom control team, because the palliative having a palliative care team, we call palliative care, kind of has a, I want to say, I don't want to say a negative connotation, but it's not really about end of life care. It's about, controlling nausea. It's about helping with anxiety and stress.
Oh, so good.
I like that.
Oops.
Yeah, we got an affirmation. So yeah, and we in our house service we have a board certified palliative care physician, and we also have a psychiatrist. So as stated, anxiety and depression is common. There was a study that showed that 32% had elevated depression scores, and that's natural. You're going through a huge surgery, an incision that's from your breastbone to your pubic bone, and for every organ that has to be removed in order to render you no evidence of disease, there's an associated complication, like removal of the spleen, removal of the colon, removal of the uterus. And so there really is a need for psychologic support, whether it's in the form of um, um, our mental health, mental wellness coach, or our psychiatrist on the palliative care service, or a caregiver. So recovery optimization involves, at least for our program here, enhanced recovery after surgery protocols. And what we can do is we can talk about a structured rehabilitation. So in terms of the goals of rehabilitation, why does exercise matter after cytoreductive surgery? Again, the surgical burden with a multi-organ resection and the heated chemotherapy, not only are you having the potential side effects or potential complications of each organ that's being removed, you are also having an inflammatory and catabolic response that persists for, I would say, 2 to 3 months. You can have changes in your body composition in terms of sarcopenia. You can lose muscle mass. You can have fatigue, deconditioning, and delayed bowel recovery. And even when your bowel recovers, depending on how much small intestine or colon is removed, then your bowel function may be different from your preoperative baseline. In terms of benefits, exercise decreases potentially the complication rates, increases the muscle strength and the O2 threshold, increases chemotherapy readiness. So, if some of you may have had chemotherapy prior to surgery, depending on depending on the grade of your disease, and then have surgery, and then kind of have the sandwich approach where you would have chemotherapy after. So exercise increases the ability of having the return to intended oncologic therapy, and also increases health-related quality of life, self-reported quality of life. So in terms of comprehensive goals, the physical aspect, we look to restore function and prevent muscle wasting. That also goes hand in hand with nutritional goals to promote anabolism instead of catabolism, GI recovery and wound healing, and then psychosocial in terms of managing anxiety and stress reduction. So we really have to have, this is by no means all inclusive, to have a team to help our patients. For our prehabilitation, which I'll talk about soon, we have a physiatrist who is double boarded in anesthesia and PM&R, physical rehabilitation, physical and rehabilitation medicine. We have a registered dietitian from the Cancer Center. We have a mental health wellness coach as well, and we have an enhanced recovery nurse. But, in terms of rehabilitation, is reactive. It begins in the hospital after surgery and continues in the postoperative period. So a sample exercise program of rehabilitation would be graduated. So in the acute phase, while you're in the hospital, we're talking about, bed mobility, incentive spirometer, sometimes passive exercises where you're with either an occupational therapist or a physical therapist and you're at the bedside. We try to get patients up by post-op day 1. It's super difficult, especially when, if it's a long surgery that's going into the night at 10 p.m. And let's say because it's so late and because of all the fluid shifts, then you're on the ventilator and then you're liberated from the ventilator the next day. Some of you may have had that experience. So it's not always possible to get people up, get patients up by post-op day 1, but we try, because the whole idea is, with this exercise program is to prevent atelectasis, which is kind of collapse of the lungs, because as you have this big incision, your breathing is very shallow, and as your breathing is shallower and shallower, then your lungs kind of collapse. And then VTE is thromboembolism, venous thromboembolism, or clots that occur in the legs or in the lungs. And then ileus, of course, your sleepy bowels. And then kind of in the early recovery period, which, at 1 week, you may still be in the hospital, supervised low impact activity like walking. I don't have patients in the hospital in a recumbent bike or an exercise machine, but this is typically for when patients are able to go home. And then kind of this is when you have introduction of gentle resistance and core rehab training, with the ideal frequency of, this is a lot. I know it's a lot, 20 to 30 minutes a day. I don't even think I don't do pelvic tilts or bridges or wheels 20 minutes a day. I don't know if I can. I can. You can too. And then kind of the intermediate phase, where you kind of progress to more moderate activity, maybe introduce light weights instead of bands. And then, this is with the goal of 150 minutes per week. And we'll talk about our prehabilitation program as well. It's pretty ambitious that our patients kind of work up to this. And then long term, as you're starting to get close to your baseline, fitness level, I can think of one of my patients who used to hike and bike until I did a repeat cytoreduction. I actually operated on him a couple times over the last, I think, 8 years, I want to say. But he came in, biking and hiking, and then, with my surgery, just had kind of a profound decrease in functional capacity. But we made it a goal that we would get him back to, he made it a goal, and we made it a goal that he would get back to hiking and biking again. And lo and behold, he's back to doing that. One of the measures that is common in the literature is the 6-minute walk test, also abbreviated here 6MWT. That's basically how far you can walk in 6 minutes. There are other metrics like the stair test, grip strength, and then kind of a sit to stand that can be monitored. In terms of nutrition, it's going to be high protein, high biologic value protein, with a target of 1.2 to 2 grams per kilogram per day, small frequent meals, working around GI complications like an ileus or a leak of the connections, or, God forbid, the dreaded fistula. And we have inpatient, we have dietitians or registered dietitians who will make rounds on our patients. In terms of stress and mental health, because of the high prevalence of anxiety and depression, which is naturally, it really comes hand in hand with a surgery this intense. There's also, the idea that you have this, large incision from, your breastbone to your pubic bone, and some of you may have had, either permanent ostomies or temporary ostomies, and in the time that you've had the stomas, I know that it's a huge impact on your daily living, and potentially your quality of life, as you have to kind of think about social situations ahead of time, even without an ostomy. If you have a good portion of your colon removed, now you're thinking, okay, if I'm going out, I have to make sure that I'm near a bathroom, just in case. Or if I'm on a plane, there are issues with that as well, especially with, say, an appliance when you have changes in cabin pressure. These are kind of things that I would say a lot of us as physicians don't think about, but that's, you as a patient and caregiver probably experience this obviously firsthand. Some interventions that, we usually talk about are, I want to highlight mindfulness and relaxation techniques like breathing, mindful breathing, guided imagery, and we'll talk about that in terms of prehabilitation, and apparently stress and inflammation are linked, and so managing both improves outcomes. So this is a super busy slide, but one of the questions is, how does a structured rehabilitation program impact functional recovery, quality of life, and complication rates in patients who've undergone cytoreductive surgery and HIPEC? So this is just a table of 10 representative studies. I just want to, focus on the rehab type intervention that all of these studies have. They range from, physical therapy plus, pain control to enhanced recovery protocols. But you can kind of see, and fast track, which is really another word for enhanced recovery. But you can see that a lot of these rehab interventions include some form of enhanced recovery. And then in terms of, length of stay, there's usually, most of these studies show some form of a decrease in length of stay, whether it's in the intensive care unit or whether it's in the total length of stay. In terms of functional milestones, quality of life, self-reported quality of life indicators like satisfaction, basic metrics like, return to oral feeding, like, being able to tolerate an oral diet, other measures like being able to pass gas, and earlier return of bowel function. So these are all impacted by a rehabilitation program. So kind of a summary, a structured rehabilitation program for patients undergoing HIPEC improves functional recovery, decreases length of stay, improves quality of life in terms of, the metrics that are looked at, may decrease complication rates in the setting of a kind of a global protocol. And a lot of these studies that had structured rehabilitation employed an enhanced recovery after surgery program. So that being said, what is enhanced recovery after surgery, or ERAS? Well, it's not Taylor Swift. Taylor Swift is the pioneer of the Eras tour, but she's not a pioneer of the ERAS. So some of you who are Swifties may know that she purchased her music and now owns her music. So that's a big win for Swifties out there. But as much as I would like to believe Taylor Swift could be a pioneer of ERAS, it's actually Dr. Kellett, now 3 decades ago, where he had a simple question: why is the patient still in the hospital? And so, it was just a simple question. And this was really before laparoscopic surgery was um, utilized more frequently. So, in the 90s, anytime you had your colon removed, it was typically through an open incision. And he kind of had a simple program that just looked at 16 patients, looked at just educating patients about what to expect, address their pain with an epidural, use this open technique with a small incision, fed patients fast because back then, you to advance your diet was kind of a very, very long and graduated process. Mobilize patients immediately, and he called it fast track surgery. He actually published his results, and people thought that his results were they thought it was too good. A couple pioneers of enhanced recovery, Ken Fearon and Ali Lundquist. Ken Fearon has since passed away. Developed this ERAS study group just based on the ideas by Professor Kellett. And the whole idea was to have all of these evidence-based protocols for all elements, all phases of surgery. And so, when you look at the phases of surgery, you can divide it in terms of pre-admission, preoperative, intraoperative management, and postoperative. And programs that utilize evidence-based pathways to decrease variability and streamline the recovery, they tend to improve outcomes. So in terms of pre-admission, you're talking about nutritional support, optimization, education, preoperatively, selective bowel prep, for example, post-op nausea and vomiting, prophylaxis, carbohydrate load. Intraop, that's more of anesthesia domain to kind of minimize fluids, goal-directed fluids, for example, and then minimize opioids. And then post-operatively, remove drains as soon as possible, get people mobilized as soon as possible, and start a diet as soon as possible. So lots of guidelines, mostly started out with colorectal, and they've kind of, transition to more subspecialties now, gynecologic surgery, bariatric surgery, liver surgery. And then I was fortunate to be a part of the cytoreductive surgery and HIPEC guidelines in 2020. And now we're meeting again for the, part 2 of the HIPEC guidelines. The whole idea, I'll show you the guidelines in a second. It's very, it's a lot of text. So this slide is super busy, but this just shows you an example of what we give our patients in terms of enhanced recovery. What's the rationale for enhanced recovery? What should I expect? What will happen in the operating room? And then kind of a checklist, almost kind of like a pathway of what will happen during their admission at UCSD. So why is it important to provide education? That one variable alone can change the outcome of the length of stay. So this is kind of a pretty elegant study that I found that looked at patients who underwent total hip arthroplasty or a total hip replacement. They had 100 patients, and then one cohort was in a 4-day group, and one cohort was in a 2-day group. And all they said was, "You're going to leave in 2 days. You're going to leave in 4 days." And they didn't change anything else. And just setting those expectations decreased the length of stay by 1 day. And so, that kind of shows you the power of just setting guidelines and just allowing not only the physician but the patient to kind of be a partner in the care. I know that some of you as patients feel like you're just kind of going along like a float trip down the river sometimes, but you really have we want to give patients the tool to empower to be part of to empower their own care. And that'll segue later on in terms of a clinic that we're developing. So years ago, we looked at the, guidelines for cytoreductive surgery and HIPEC. And I'm just going to give you kind of we kind of looked at it in terms of preoperative, perioperative, and postoperative factors and interventions. So the preoperative phase, you can see that a lot of this talks about preoperative counseling and education, smoking cessation, and alcohol cessation. I mean, heavy alcohol cessation, heavy alcohol use cessation, a program of physical exercise. I just heard an explosion outside my window. A program of physical exercise, nutritional screening, and then also a regimen of nutritional and protein supplementation. And here they talk about oral immunonutrition as well, which I won't go into too much detail, but we also employ immunonutrition in our prehabilitation study. These are some of the intraoperative guidelines, and they pertain more to anesthesia in terms of, antibiotics, anesthesia protocols, normothermia, so making sure that your core body temperature is not too cold, not too hot. And then postoperative, a lot in terms of, analgesia, even down to like the urinary catheter. But the thing that I'd like to highlight is really early mobilization, just kind of movement and exercise. So why is that important? Well, this here is another busy slide that looks at enhanced recovery. And they looked at, let's see here, looks like about 7 studies here. And they did a meta-analysis and they looked at the length of stay and then complications. And here in the meta-analysis, when you have the diamond kind of to the left of this null bar, then it favors enhanced recovery. And likewise, in terms of complications, favors enhanced recovery. So that means that enhanced recovery, the pool sum of our knowledge of our data favors enhanced recovery, decreasing length of stay and major complications. And it does this without increasing readmissions, because here you're right at the null bar, but you do decrease the return to the operating room, any kind of kidney failure, and perioperative mortality. So this kind of segues into prehabilitation. So the surgical stress response is pretty complex. We can start here with the offending agent, which is the surgery and the incision, which causes a sympathetic response. And then from a sympathetic response, you have a cascade of regulatory hormones that causes catabolism of the muscle, and then your body is in this stress state where it's trying to produce glucose and trying not to store it and trying to break down fat as well. And so then you have a hyperglycemic response. So you have catabolism and essentially what's noted as insulin resistance, with this hyperglycemic response. So why is prehabilitation important? So this here is probably, if you have to remember anything about, this presentation right here, this line, this bold line here represents kind of your functional capacity without any kind of prehabilitation. So here you go, functional capacity preoperatively, and then you hit that surgery, you hit that huge stress, and boom, your functional capacity goes down, and you're kind of below this quote unquote functional threshold. And now you have to rehabilitate to bring yourself up above that threshold. With prehabilitation, the idea is to kind of buffer yourself up, raise your bar off, so that once you take that hit of surgery, when you go down, you don't go down too far below your functional threshold or for a long time. And so one of the exemplary rehabilitation programs actually was out of the McGill group, Dr. Carley. It comprised of a movement prescription of aerobic exercise. It's a trimodal program, and it encompassed nutritional counseling, which mandated supplementation of protein, high biologic value protein, and then anxiety and stress reduction. And so the idea here is that you increase functional reserve. So patient A is a patient who's just kind of gone through surgery without that prehabilitation, and patient B has gone through prehabilitation and has a higher functional reserve. So now we're talking about, combining prehabilitation and enhanced recovery, where you have prehabilitation focusing on enhancing your physiologic reserves, and then you have enhanced recovery, minimizing that stress response and kind of buffing up the rehabilitation. And this can work in synergy to increase surgical or benefit surgical outcomes. So components of multimodal prehabilitation, as I mentioned, nutritional, exercise, and psychosocial. So a lot of times from a nutritional standpoint, super busy slide, I know but we get, a baseline screening tool. We use a malnutrition screening tool, but a lot of places will use a subjective global assessment. We get a A1C, and then we get labs that are nutritional, like prealbumin, transferrin, albumin, CRP. In terms of exercise, we tend to use a 6-minute walk test as our metric. And then in terms of psychosocial, we have scales that, patient survey scales. We have a mental health coach, and we have a psychiatrist for the palliative care team. So interestingly, this here is kind of a table that says that, even if you just have like one of the 3 arms, a unimodal prehabilitation program, or if you have a multimodal prehabilitation program, it enhances functional walking capacity. So here's an exercise prehabilitation program, randomized controlled trial, and then there's a 33% improvement. Even nutrition does it. And then when you add kind of a multimodality aspect to it, it increases to what a proportion of patients who experience a clinical improvement in walking capacity. Here is a meta-analysis that looks at prehabilitation for major abdominal surgery. They don't limit, I want to say they don't necessarily limit to cytoreductive surgery and HIPEC, but again, looking at these 5 studies, when you're looking at overall complications, you have this diamond to the left of the midline, and then you have length of stay. I guess it kind of approaches to the left. But the short version is that looking at a meta-analysis of all these studies and pooled data, there's a decrease in overall complications and a decrease in length of stay. So looking at the data in terms of prehabilitation before cytoreductive surgery and HIPEC, 2 of the exemplary studies that I saw were these 2 studies. The Prehab components included exercise, nutritional counseling, smoking cessation, and then the other one looked at exercise, psychosocial support, and nutrition as well. And you can see that the short version is that the complications rates were decreased in the prehabilitation groups, and then the length of stay was decreased in the prehabilitation group. One study showed a delta of 3 days, another one showed a delta of 2 days. And then when you're looking at prehab versus rehab, kind of, head to head, here's a randomized trial where they looked at prehab versus rehab. And looking at the 6-minute walk test, you can see that the patients in the prehabilitation group in the solid line did better. Baseline was the same, but before surgery, post-operatively 4 weeks, and then at 2 months post-op, patients did better in terms of the 6-minute walk test when they had prehabilitation, when they had a proactive program. So we have a pilot that's been that we've had for the last couple years, and it's a very small pilot. We're trying to just accrue 10 to 12 patients, and we had funding from the CRUP endowment fund, which focuses on integrative medicine. We have a multimodal prehabilitation program pilot at UCSD. So in terms of the movement, ideally, so in terms of timeline, we identify patients ideally, 4 weeks before surgery. It was the consensus of our group that we would need at least 4 weeks to kind of really make it a meaningful prehabilitation program. And so for the movement portion, there's a one-on-one with the movement team, which is at EPARC, and I'll tell you the acronym of EPARC in a second. It's a pretty intense program where it's a combination of aerobic exercise and resistance training. There are one-on-ones, and then there are assessments of the 6-minute walk test. So EPARC at UCSD is the Exercise and Physical Activity Resource Center. And, when you're enrolled in this program, you're looking at, anthropometrics, like your weight, your vitals, your body composition in terms of a DEXA scan or a bone densimetry, a bone density scan. How about that? Movement assessments, exercise consultation, and then an accelerometer that they have you wear. And it's throughout the pre, peri-op, and post-operative period. So this is a sample of the brochure, the packet that they give our patients, prehabilitation for cancer surgery. And here's some sample exercise descriptions. So the exercises that are prescribed have been designed to improve flexibility, strength, balance, and coordination. And so, each exercise that is prescribed by the study coordinator may end up targeting different parts of the body, and it may end up targeting different goals like strength or balance. So here's one of the examples. So ankle circles. This focuses on flexibility, and so these are instructions of how to do it. And our movement coordinator, her name is Shoshi. She goes through mostly virtually, but because you have to have a body composition, you have to, there is a in-person component, but for the most part, this is virtual. Here's an example of wall sits and wall squats, which will focus on flexibility, strength, flexibility, and C is coordination. And this exercise encompasses all strength, flexibility, balance, and coordination step-ups. And then there's a log, and there's active involvement by, our prehabilitation study team. And then in terms of nutrition, again, the timeline is very similar up to, we identify patients who are going to at least have 4 weeks of intervention. At UCSD, we use a malnutrition screen. I think you guys can hopefully see my mouse cursor. The focus is on high biologic value proteins and complex carbohydrates. The focus is also on having adequate protein intake, at least 1.2 grams per kilograms per day. And then in addition to nutritional supplementation, we also supplement with immunonutrition. Our immunonutrition of choice is Impact Recovery by Nestle, which is taken 2 to 3 times a day for 5 days leading up to surgery, and then post-operatively as allows. As you're all aware, sometimes you can have an ileus and delay to bowel function for up to a week. This is kind of the global prehab timeline here, prehab nutrition, surgery, prehab in terms of preoperative nutrition guidance. We have a different set of registered dietitians inpatient who coordinate with the outpatient. And then once patients are discharged, they go back to the integrative medicine registered dietitians. Here's a sample of the program or slides that one of our registered dietitians made for our patients. She called it SPEAR, Surgical Prehabilitation, Education, and Recovery. She talks about the importance of nutrition for surgery. So anywhere up to 50% of patients who undergo surgery will have some degree of malnutrition. And that's why it's important really to enroll, I would say, everyone in terms of a prehabilitation nutritional program. But the benefit of nutrition is going to be associated with decreased infections, healing, ulcers even, if you can believe that, and length of stay. So here's kind of an overview of the prehabilitation nutritional process. It can go, it starts out with, recommending a high biologic value diet. It also incorporates the enhanced recovery carbohydrate loading. We didn't really talk much about this. And then also immunonutrition. And then post-operatively, we have gum chewing to help stimulate the bowels. The data is kind of mixed about, if it actually helps jumpstart your bowels, but it's a very low risk intervention. And then recovery. So our registered dietitians, just recommend eating a well-balanced diet, kind of a healthy eating plate, if you will, kind of a, 50% vegetables, 25% grains, and 25% protein. Obviously, this may have to be modified depending on the length of bowel that you have remaining, or whether or not you have an ostomy. Again, a high protein diet. And then here's an example of a 150-pound person and how much protein they would need. One way of kind of measuring out the amount of protein is the size of the palm of your hand. Hydrate, 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 hydrate. When I see my patients post-op, say about a week or 2 post-op, most of my patients won't have an appetite. And at that point, I kind of say, food is kind of like medicine, because now you have to be more conscious of it. But you probably won't have an appetite, but the main thing is to keep hydrated. What color is your urine? Make sure it's light and not tea-colored. You want to go with, water or some kind of oral replacement therapy, kind of like like a Gatorade or Pedialyte, but you want to avoid caffeinated and alcoholic beverages. Interestingly, our registered dietitians recommend staying active because this goes hand in hand. Physical therapy, physical activity can actually improve surgical outcomes, speed recovery, and actually can reduce fatigue. So it's kind of like when you're, you can imagine HIPEC as being a marathon. It's like preparing for a marathon. Initially, when you're training for it, you're pretty darn tired, but then as you're working through it, you get stronger and stronger. And again, the goal of 150 minutes per week is pretty lofty, but that seems to be the number that's out there in a lot of the prehabilitation studies. Side effects that, that you'd have to deal with in terms of post-op is, nausea and vomiting. I've had a patient, and maybe some of you have experienced this, where it takes 3 months before you can even take something in and feel like you want to, like you're actually eating something rather than taking it just for its nutritional value. And our registered dietitian recommended, broths and even kind of supplementing with any of these over-the-counter stuff like Noon or Mio or Liquid IV. And then kind of depending on where you are in the spectrum, if you're having, short bowel or short gut, you may have to deal with diarrhea, and you have to increase soluble fiber. You have to, be on a brat diet to help modify your diet. But sometimes you may need pharmacologic intervention like Imodium or Lomodal. And then, sometimes you actually have, you kind of have the other end of the spectrum where you have constipation, maybe because you're not keeping hydrated. And then, fatigue and poor appetite go hand in hand, but the more that you exercise, the better that both get. Okay. Actually, so mindfulness, similar timeline, and the whole idea is to be with a coach for at least 4 weeks leading up to surgery. The wellness coach will go over kind of, like a body scan or mindfulness, and then help tailor the program and, to and even potentially prescribe meditation. Super busy slide, but basically all these studies show that some kind of mindfulness-based intervention also positively impacts pain relief and physical functioning. These are not necessarily studies of HIPEC per se, but these are kind of randomized controlled trials that looked at, total joint or breast cancer patients, or minimally invasive surgery or abdominal surgery. So our mindfulness program is actually pretty intense, and it basically starts with kind of a introduction and each session with, her name is Helen, is our wellness coach. She works on all of these, like uncertainty, non-judgmental awareness, creating space, working with pain and discomfort, and then she kind of allows for home practice. Everyone kind of arrives at a different level. Some people have never meditated in their lives. Other people are, avid meditators. And so this is kind of Helen has put out a video for patients for mindfulness as well. And she, she has a very soothing voice. This is really her slides, not her video. But, she kind of talks to people about, what mindfulness is, talking about the moment to moment aspect. Just kind of doing, the whole idea of even doing, will be on another slide. Doing a body scan is just kind of like focusing on the now, and as simple as kind of like listening to yourself breathe. And the benefits, are multimodal, actually, psychological, physical, psychological in terms of, decreasing stress and anxiety, physical in terms of like being synergistic with pain control, and then neurologic in terms of neuroplasticity, where you're kind of almost changing your mindset. And then mindful preparation, we kind of talked about that, a lot of things like, just non-judging, accepting, allowing, trusting, kind and gentle thoughts, awareness of your thoughts, your feelings, and your body sensations, and just being okay with it. I mean, that is normal. This is a body scan. I actually haven't checked this QR code. Maybe you guys can check it out. I think this is actually the video to the body scan and how to do a body scan. Just stop, pause, take a deep breath, observe, and proceed. We're kind of wrapping up. I know that I'm going over a little bit of time, and I hope you guys are sticking through. But to kind of help with the enhanced, this is separate from the prehabilitation study, but to help enforce the preoperative portion of enhanced recovery, we're piloting an Empower clinic. Empower, I don't have it up here, but it stands for Education Maximizing Postoperative Outcomes with Enhanced Recovery. We plan to start this in the coming month, where we just have a group of, just 6. It's going to be virtual. It's going to be an enhanced recovery nurse, Dr. Joel Castellanos, who's our physiatrist/anesthesiologist, Tracy Roberts, who's our Moores Cancer Center registered dietitian, and then Helen, who developed the program that I just showed you. It's going to be me, and it's going to be kind of almost like a group visit where we kind of go through, everyone kind of goes through like baseline videos of, mindfulness, nutritional counseling, and exercise, and then we kind of have one-on-ones afterwards. And these are the educational topics, essentially, and there are videos associated with it. And that is wrapping up. I mean, in summary, cytoreductive surgery and HIPEC is associated with just an immense amount of physiologic, nutritional, and psychosocial stress. The goal of rehabilitation is to restore functional capacity. Enhanced recovery is an important component in rehabilitation, but rehabilitation proactively takes that rehab component and increases functional capacity before surgery, and it's associated with decreased length of stay and morbidity. So in summary and conclusion, combining enhanced recovery and rehabilitation may actually decrease length of stay and morbidity in patients undergoing cytoreductive surgery and HIPEC. Thank you.
Thank you, Dr. Veerapong.
Yes, thank you. I mean, it really underscores how we patients can play a role in our best outcomes. And so it was a good reminder. The QR code, in fact, was a link to a bunch of mindfulness videos. So thank you for that.
Excellent.
We've got a bunch of questions.
Do you want me to just go?
Yeah.
I'll just go down the line. The first initial questions aren't necessarily rehab or prehab, but I think they're super important. They're obviously very important. So ostomy, how often is that used with HIPEC and cytoreductive surgery, and what are the deciding factors? It's kind of interesting. I think it has to do with experience. When I was first starting out, I would say I did a diverting ostomy where, it's very typical to have your right colon removed and then maybe a portion of your rectum removed. And it's very common to have 2 connections. And I used to give a temporary ostomy to about 50% of my patients. This is when I was first starting out, just because, it's very important. We don't want any leaks. We don't want any fistulas. I actually cannot remember the last time I've done an ostomy. So I don't do them often anymore because of the technical aspect of actually, doing the connection. The connection that you worry about the most is the connection between your colon and your rectum, and if it's like really low. But with experience, you can kind of preserve the rectum and kind of roll up the tumor and then be able to make a higher connection. And so I don't do it anymore. And I was actually surprised because at ACT, you know, there was still like a debate about ostomies and the prevalence of ostomies. And then I'm not going to say who said it, but someone says, I divert all my patients. Maybe Adele, you know, but I divert all my patients. And I'm like, oh, well, I divert almost no one anymore. And so we actually UCSD, I think we have a paper talking about like you know, our ostomy rates. I think it's like less than 5%. And the deciding factors usually are the number of connections and then whether the connection is really close to the anus, because when the connection is so low in the pelvis, you worry about a leak. And if it's a leak in the pelvis, can be disastrous. And, you know, if you have a leak there, then it's hard to put things back together, and that patient might need to have a permanent colostomy. So right hemicolectomy, okay, what is the purpose for this? So it just depends on your disease process. So for patients who have a low-grade appendiceal mucinous neoplasm or a lamin, that is a type of mucinous tumor that typically does not spread to the lymph nodes or to the bloodstream. An adenocarcinoma or a cancer can, and this kind of comprises, you know, the signet ring cell, the goblet cell. And so when there is that potential for spread to the lymph nodes, you will want to harvest the lymph nodes, and the lymph nodes are along the arterial distribution of the colon. And so if you harvest those lymph nodes, you're taking the blood supply to the right colon, and then you have to take the right colon. What is this done if no disease is present in that area? Yeah, that's why. So if it's a low-grade appendiceal mucinous neoplasm, a lamin where it does not typically go to the lymph nodes, then the reason why I would remove the colon is only because it's on the surface and I got to remove the disease. But for a cancer that can spread to the lymph nodes, in theory, you want to harvest the lymph nodes so that you can just take out all of the disease. Do patients normally experience GI side effects? It depends. So if you're just removing the right colon, it can be variable. Most patients in the first few months will have maybe an increase in the bowel movement or a more liquid quality. But most patients just removing the right colon will be back to normal within a couple of months. But if you have to, you know, take out the small intestine and, you know, a portion of your other colon or rectum, then, you know, if your baseline was 1 bowel movement a day, it might be 2 bowel movements. And how much is normally removed? It just depends. The whole idea of going into surgery, it's to spare the bowel. And sometimes you have to anticipate future surgery as well. So you don't want to go buck wild. You know, you want to spare as much bowel as possible, because you have to think about sometimes when you have especially when you have a low-grade process, and you have a recurrence, then you're expecting, okay, you know, in you may require a couple surgeries throughout your lifetime. So we want to spread it out, and we want to spare all bowel to preserve your quality of life. Neuroendocrine tumors. So don't normally. Can you give us a basic overview? So neuroendocrine tumor is kind of, it can behave like adenocarcinoma, where it can go to the lymph nodes and it can go through the bloodstream. And when it does go to the bloodstream, it can go to the liver or the lungs, as opposed to a lamin, typically kind of tumor droplets. But neuroendocrine tumors can also spread by tumor droplets. How are the symptoms differ? I would say for the lamins, the symptoms are mostly associated with the bulk of the mucinous jelly. You know, even though like these lamins, if you look at them under the microscope, they actually kind of look like polyps. They don't look like like cancer. But the problem is they can behave in a malignant fashion where, you know, now you got cells that are spread. The classic analogy I give is just imagine the inside of the room that you're sitting in, kind of like the inside of your abdomen, and you take a can of soda and you shake it up, you open up and it sprays all over. That's typically how lamins behave. But neuroendocrine tumor can do that as well. So I've had patients who've had spread in their peritoneal cavity, and I've done cytoreductions for it. There's no data, there's no good data, I want to say, to do a HIPEC, but there is good data to remove it, just like you would for the cytoreduction component of, say, like an appendix tumor or cancer. How are treatments different? Well, lamins, you typically don't do chemotherapy. Appendix cancers, especially like the higher grade ones, you may involve some IV chemotherapy. With neuroendocrine tumors, you typically don't give chemotherapy unless it's like a super, super high grade carcinoma. You typically give something like a octreotide, which is a somatostatin analog, which helps stop it. It connects to the receptors that helps kind of stop these tumors from growing. They don't kill it, but it kind of prevents it from growing. Surveillance, it's variable. For something that's slow, I would consider like lamins to be slow growing. I typically do something like, every 6 months for 3 years, and then every year for a couple of years, and then every 2 years until you hit the 10-year mark. Okay, surveillance. What is the time frame? Yeah. It's very different in terms of the guidance, and it depends on if you go to a surgeon, it depends on if you go to an oncologist. Some people do MRIs, some people do CT scan. Dr. Barone does MRIs. Some people do CT scans, and then some oncologists would do PET scans, which I don't typically do because for me, I typically look at tumor markers and a CAT scan, and if things look like if the tumor markers go up a little bit or something looks funny on imaging, then I have a low threshold to do, say, a diagnostic laparoscopy where I go in and take a look inside. That being said, scans can be tailored. If you have a high grade process, or if the things look a little suspicious on this current scan, I might say, let's not wait 6 months. Let's just do 3 or 4 months.
Dr. Veerapong, there's some more questions further down that were submitted while you were speaking.
Yeah,
I'm gonna just look at them real quickly. One was asking about airplane travel. One was asking about chemo and bone density loss and how Prehab would address that. One was asking about goblet cell and right hemicolectomy, and then the last one submitted. Well, I guess not next to the last, immunotherapies at UCSD, and then the terminology cured versus NED. So if you want to start with maybe that question about airline travel, you mentioned, the possibility of the pressure in the cabin.
Yeah. I think, I have a lot of patients who come from Northern California or from Hawaii, and I usually, after my first post-op visit, if the wound is looking okay, if there's a tube that is indwelling and has been removed, I usually clear people for travel, and it should be okay. It just gets a little tricky if you have an ostomy, because you have to be aware of the cabin pressure, and it gets tricky if there's a drain, because then you have to go through TSA, and I'm not sure exactly what they do. Actually, maybe some of you who've traveled with drains can enlighten me. I'd be kind of curious about like how you're able to go through security. But yes, how do you deal with plain, issues of needing to go to the bathroom frequently with normal bowel issues? I think it's about kind of positioning yourself close to the lavatory and maybe anticipating before boarding, and who knows, maybe getting an indirect flight where you can have breaks,
Do you mind if I've had to think about this a lot over the last 15 years since my surgery, and I went to Australia, my longest trip. And my strategies are, I try to reduce what I eat before I travel, just less load in the bowels. I stick to known foods, nothing weird that you're going to have a weird reaction to on the plane. And before, I don't drink any carbonated drinks, try to reduce gas. time your medications. I sometimes will take like a gas X because the changes in pressure definitely affect how my bowel feels. And then I always try to get an aisle seat close to the bathroom. And, if you feel like you need to get up and go to the restroom, go. Sometimes you might not have to, but I just feel like, sometimes that anxiety really weighs on you. Like, am I going to have an embarrassing accident or something? And so I just get up. Sometimes I get up 3 or 4 times on a longer flight, and it's just more out of caution. So those are my tips that I've put together for myself over years of travel, having to deal with these issues.
And I see Lauren says cholestyramine and aisle seat, which cholestyramine, if Imodium doesn't work and if diet, modification doesn't work, that's sometimes cholestyramine is added. How does Prehab?
Yeah,
Oh,
the rehab, that's an interesting question about the bone loss.
good question to be seen with our study because we're doing a DEXA scan before intervention, right at intervention before surgery, and then afterwards. Hopefully it'll um, impact bone density in a positive way, as well as muscle composition. So via email, for a ruptured goblet cell adenocarcinoma with extraappendiceal mucin, is prophylactic CRS HIPEC best or right hemicolectomy sufficient? Would you be able to break it to percent recurrence rate, overall survival? So if there's an adenocarcinoma, then if someone comes in with, let's say, appendicitis, and then it was ruptured, and then it turns out that this is a goblet cell adenocarcinoma with mucin on it, then usually, my pre-op workup is to, review the pathology, make sure that our pathologists agree, because we do have a 30% discordance rate with outside hospitals, like less experienced hospitals. Like obviously, if you're coming from Mayo, we wouldn't necessarily do that. Then we make sure that you have adequate, scans of the chest, abdomen, pelvis, tumor markers, and then a colonoscopy typically. And then the way I approach it is that I will put a camera in and take a look, and if there's any evidence of disease, then I would stop and we would talk about doing a cytoreduction and HIPEC. But if there's no evidence of disease, then I would do a completion removal of the right colon. Um, different people have different, I guess, philosophies. Some people, even if there's no gross disease, will do the right hemicolectomy and then do the HIPEC. I have done prophylactic, quote unquote, prophylactic HIPEC where patients have come in with, a history of a perforation and mucin and then has had the right colon out and they have no evidence of disease. And I've done prophylactic HIPEC, but there is no data for that. And I kind of moved away from it. And I kind of figure, at some point down the line, like, so I don't know what the recurrence rate just depends. If it's a high grade process, then the recurrence rate is higher. If it's just acellular mucin, then the recurrence rate will be lower, not zero. But recurrence rate and overall survival really just depends on the actual aggressiveness or grade of the tumor. So short versions, I've kind of moved away from prophylactic HIPEC. Some people will, put a scope in and just do a laparoscopic HIPEC. But me, I feel like if there's going to be gross disease that comes back, I want to take that opportunity to do the surgery and then the HIPEC at the same time and kind of keep it in the back pocket. Research in terms of immunotherapies. We typically, for patients who are candidates for immunotherapy, like whether it's like a loss of one of the mismatch repair genes, the proteins, a loss of the mismatch repair genes, or if it's a high mutational burden, or if it's a PDL1, if there's a PDL1 target, then that's when we do the immunotherapy. Dr. Lowy has kind of championed from, bench to bedside the use of Ibrance, which is a medication that's used for metastatic breast cancer to help quell or keep disease stable in patients with a GNAS mutation. Will the terminology ever be used cured? Maybe. It's kind of, I know it's like splitting hairs, but technically when there's disease to the peritoneum, it's stage 4, as you're aware, when it's GI. When it's a gynecologic, it's stage 3C, unless it's outside the peritoneum, then it's stage 4. But 10 years is about right when, I would say, you're cured. And the only reason we say we do 10 years is because a lot of you are aware that the low-grade appendiceal mucinous neoplasm is just so slow growing that you just have to. Dr. Lowy anecdotally has had patients who have like come in right at the 10-year mark. Well, I don't want to scare you, but at the 10-year mark, and then like, oh, there's a little something, and then you just take care of it. It was kind of more of a touch-up surgery compared to the big one, Okay. Paula can address I don't know which question she was referring.
Paula was, I think, referring to the travel tips.
Oh, yeah. Does she want to?
Paula, up to you.
Okay. Well, Paula, chime in if you like. We'll go on to the next one. Are there any side effects to be mindful for exercise, or that would pelvic floor exercise benefit with? Actually, that's a really good question, actually. I think it would. I don't have data on it. But it's particularly helpful, for example, if you have like a diverting ostomy and you haven't used a normal channel. And so I always tell patients to make sure that they do Kegels before we reverse, because once you reverse the ostomy, the colon that used to see action hasn't seen action for a while, and then you may have a lot of loose bowel movements. Would you do abdominal strength prior to strengthen the abdominal muscles? I think that's reasonable. I think kind of in the context of just like a global exercise program. I think it's okay to do it before surgery. I would wait until after, about 6 to 8 weeks after surgery before you engage your core, because whenever you're going to have a large incision, and whenever your incision heals, you only get 80% of your original tensile strength. Steve, curious to hear your thoughts about surgical menopause comment. So this occurs usually it occurs more markedly in patients who are of childbearing age. So let's say like a 25-year-old. I mean, anyone who's premenopausal, but a surgical menopause can actually be very abrupt. And so you have to look out for vasomotor symptoms like hot flashes. And if that's the case, and it's kind of impacting quality of life, then sometimes we will start estradiol. What's the difference between Signatera? They're just kind of, Signatera looks at circulating tumor DNA. It looks like it looks at actual DNA, tumor DNA in the bloodstream. Genomic testing kind of looks at profiling, like some kind of mutation that could be actionable by certain types of whether it's chemotherapy or whether it's immunotherapy or whether it's something like, the Ibrance for breast surgery. Okay. I think we got most of the questions. I hope I didn't skip anything.
Wow. That was a lot.
It was a lot, but just amazing, great information.
Oh, Paula said she'll address the flying with the knot. I'm kind of curious. I mean, because I think you're welcome, Melissa. Because this will help me with when patients, do you wanna address it here? Because this will help me with when I have patients with ostomies.
or if you want to put comments in the chat, maybe just
Oh,
high
yeah.
level.
Yeah, I know it's a long Zoom.
I would just say too, on things that I found helpful when I had my ostomy for 6 months, I joined a local ostomy support group here in Austin. And because I was recovering from surgery, I never went to the meetings, but I got their newsletter, which was so extremely helpful. It gave you tips for all kinds of things, travel, advice like, oh, maybe you shouldn't give blood if you have an ostomy. One physician who had an ostomy gave blood and had this really depleted reaction. Anyway, I would just say that for a lot of things like travel and other helpful tips with an ostomy, try to find a good local or national, now that, everything's online, it doesn't matter if it's local, a good group that provides a lot of practical tips from people like Paula who have ostomies, whether it's for this condition or other reasons. You will get some really great tips through those groups.
Hi, this is Paula. Do you hear me?
Yes.
Hi. Hey, Dr. Veerapong, I'm from St. Louis. How dare you leave us?
Uh,
I was getting ready for surgery, and I had talked to a surgeon at BJC, and he said, "Oh, go to Dr. Veerapong," and then that was it.
was it Dr. Glasgow?
Yes, it was.
He's awesome. He's also, I think, has left St. Louis, and then there's, I think, a Dr.
Yes.
Trang Nguyen, maybe, and then there's Ed Barnes, and then there's Dr. Jenny Keller.
Yeah. At the time, I went up to UPMC. That's all. It's still great.
Then you had excellent care.
Yes, exactly. Anyway, flying with an ostomy, which I have done. These are just things off the top of my head. Always fly with an extra ostomy bag. If you have ostomies, you know that sometimes the tape lets go or something happens and you need to have one with you. Some of these have been mentioned. Don't drink carbonation beforehand, because many times what happens in your bag, you have more gas than you have any substance. So, also the change in pressure, I was not aware of. I never had that. ILC, yes. That morning, if you're going to fly, don't eat a huge breakfast or a lunch right before. Somebody with you may say, yeah, let's eat lunch. Don't do that, because as you know, if you have an ostomy, it's going to come on through, depending on how long or how short it'll take. And you don't want more in there. Just eat very lightly. Plan to eat after you get off the plane. You might want to take a little solid fragrance thing. You can't take aerosols on the plane, but there are little solid things that you can be nice to the person behind you and wave that around in the bathroom when you come out. TSA, all I've ever had them do was usually I may have to lift my top. They have you run your hands over the bag and then they test your hands. I guess for explosives. Yeah, they don't want to know any more about it usually. They're like, whoa.
Out of curiosity, do they look at the volume greater than 3 ounces in the bag? I know maybe
they never have for me.
Okay.
I just have to rub my hands over it and then they test my hands. I don't know, that maybe go in there often enough to empty when you get the opportunity. Sometimes you'll see when you want to use the bathroom and there's a line standing there. So make sure you kind of watch that, that when there's not going to be a line there. And also deal with it before you get on the plane, right before you're going to board. And then right when you get off the plane, go find a bathroom and take care of whatever volume you need to that is accumulated in your bag. So, I've never had to have a note from a doctor or anything about that. And usually the agents, when they see your bag, they're like, oh yeah, okay. Because a lot of times they're not familiar with that. And it kind of wigs them out sometimes. But yeah, just just watch the people in line. Make sure you get in there often enough. Is just one of the things I would say. And that's just off the top of my head. Probably I'd think of a couple other things, but that's usually it. You can certainly fly with that and not worry.
Awesome. Thank you.
You're welcome.
Quick question. Has anyone traveled with a drain or a gastrostomy tube?
Yeah, my husband has, Dr. Veerapong, it's Connie. So depending on where he's going, I will send his supplies ahead of time because you need an IV pole, you need the Joey. He will carry the Joey on the plane with him. But depending on how long he's visiting, I will send the Vivanex, the nutrition, all the other supplies, the 4x4s ahead of time. And that's worked out very well. We've had to rent an IV pole for him. So checking out local DME companies and just know where those supplies are and just kind of have a checklist ahead of time, what you're going to need. 4x4s, the tape, the 60 cc syringe if needed, and of course, the Vivanex, the nutrition that is needed. And we don't really need it, but we do get a letter from his oncologist for TSA just explaining what is going on. He's never had to touch it with his hand. He has a MIP key, but prior to that, they're looking at the longer tubing, but he hasn't had an issue. He makes sure that anybody with SBS or nutritional compromise, his medication, the Lamodal, he, like everybody else, he doesn't eat a lot, he doesn't drink prior, but he makes sure that he has those anti-diarrheal medications with him while he's traveling. And any kind of antiemetic he will have with him, just in case. And it's worked out well so far, knock on wood.
So then does the nutrition, does it meet you on the other end, or can you bring it on board?
You can bring it on board, but depending on how many days that you're staying, it can be rather cumbersome. And also it's a powder. You don't want to take the risk of them, let's see what this powder is. So it's worked out for us so far. When he's traveled, I just go ahead and send it to where it needs to be ahead of time.
That's good to know.
Mm-hmm. And the other travel tip too that I have for Willie, and this is for anybody, in the notes on his phone, heaven forbid you need any kind of medical care. Write down your oncology, your surgeon, your medical record number from the hospital, any kind of allergies, and just a very brief summation that you do have appendix cancer. Those kind of things are very helpful because heaven forbid, if you're in a crisis situation, you forget. So it's just nice to know. And then the other thing when traveling, I look at the various hospitals that are surrounding the location that he's going to see where and if there is a center of excellence. And then like he visits his brother and I send my sister-in-law. I'm a little crazy with some of this, but his medical history, just so she can share with any of the clinicians that he may or may not come in contact with.
So when you say you put it on the phone, do you put it on like the screen lock? Like
on in your phone, the notes in an iPhone, you have the section for the notes.
Mm-hmm.
It's his name, date of birth, the facility that he's gone to, the medical records, because there's a lot of access, across country. So it's just very helpful. And he's had to use it once, so because he couldn't get a hold of me.
Got it.
Mm-hmm.
Are there any other questions or comments? This was such a fitting. Oh, Anne, did you want to say it's good to see you? I saw you off cam, but wasn't sure if you had a comment. Great.
Sorry, Zoom has changed since I've last been on it, so I couldn't raise my hand. I was trying to find the icon. I just want to thank Dr. Veerapong. It's been 5 years since I last saw you on Zoom. I was a new patient at that time, and I was just recovering from a right hemicolectomy. And during that time, you were just so comforting. I was actually scanning you my medical records during the Zoom, and you had set me up with, helped me set up with Dr. Deneen at Moffitt. So I am doing absolutely wonderful since I've seen you, NED, for 5 years. So just living a great life, and just wanted to thank you for all your help 5 years ago.
I'm glad you were able to connect with Dr. Deneen because he's amazing. So you found
Yes.
an
Yes,
amazing clinician and doctor and a caring human being.
absolutely. And I'm down to yearly scans, so I'm doing great.
And thank you for that. What a fitting way to, again, acknowledge our 5 years of doing all of the heavy lifting. And I think before we start losing people, I know, Charmaine, we wanted to talk a little bit more about just reminding people that, we are totally volunteer run and donation run. So did you want to make a few comments?
Yeah, I did. I think for those of you who come to Zoom regularly, we don't do a pitch every week for fundraising, but at the 5-year anniversary, I thought it would be appropriate just to mention exactly what Adele just said. If you'd like to make a donation to PALS, you can do so on our website at pmppals.net and then /give, and you can find our donate page. And we really are proud of this program. We're proud of the service that we've given to people. Your donations will go to support this program and just overall all of the things that PALS is involved in, like Adele mentioned, the card program, the bear program, the other things that we're involved in. A lot of people give their time, and like Lindsay Barat's dad donates those blankets that we send out. So we appreciate each and everything that anyone does for us to keep our programs so vibrant and allow us to expand them and serve all of you. We're so glad to see so many new names here today, and we hope that you'll come back and join us for our support calls twice a week, Wednesdays and Saturdays. But again, we are strictly donation driven. We're all volunteers here and give our time and our money to keep this going because we know it's just a huge service to this community. So, and we couldn't do this without the physician support. Dr. Veerapong has been a friend of PALS for so many years, and many other physicians as well. I don't know that we mentioned, Adele, that Dr. Veerapong is chairing our medical advisory committee for PALS. This is a group that will advise mostly the board and our staff about reviewing the accuracy of our information online. We're going to be doing some updates and things like that. So we really appreciate all the support that the medical community gives to this group.
No, absolutely. And while I see our two meetup co-chairs are on camera, Roberta and Lindsay, while we have the group, why don't we talk a little bit about our upcoming meetup? And one of our most excited participants is Matthew. You better be there.
Sure. Thanks, Adele. Lindsay, feel free, jump in. So once a year, we gather in person. So these little squares all come to life. And it's amazing how deep the relationships end up forming via Zoom, and then we get together in person and magic happens. So we have a lot of scheduled programming, presentations, medically potentially. We don't have our set programming to share just yet, but we'll be meeting in Charlotte, North Carolina, East Coast for the first time for one of our meetups. So we're really, really excited for that. There'll be wellness things, there'll be social things. It really is an absolute blast. You can register. We have all the ways through our website to register. And then it's a lovely hotel and lots of things included. And it's promised to be a great time. What else do we have, Linz?
I put a link in the chat that has more information. We have an FAQ, frequently asked questions about the meetup, so that should answer all your questions. And I just want to add that it's open to everyone. So even if you don't come on the Hope Zooms weekly, or if you've joined once, you know, it's for everyone. So anyone affected by appendix cancer, more than welcome. And we love meeting new people, seeing new faces. I feel like Matthew should be the spokesperson for the meetup, but it'll be great. So check out the link. And if you have any questions, reach out to Roberta or myself. And we hope to see you in Charlotte on the East Coast.
Yeah, and it is, to be clear, it is for patient and or care partner and or other members, adults of your team that want to experience, you know, the full flavor of live and in-person PALS content. So it is not just for patients, it's for anybody that, like Lindsay said, has been affected by your experience and would like to join us.
These Zoom meetings do a lot, but that meetup is like brings it to a whole different level. When you have those moments where you feel like no one else is going through anything like this and no one understands your thoughts or anything and your worries for the future, for now, it just it makes it it's worth the trip in milestones. It's an amazing time.
Yes. Dr. Veerapong, our heartfelt thanks for your generous time this morning and all the volunteering you do for PALS and really all the care and concern you have for our patient and caregiver community. You know, we greatly appreciate it. And it was early for you this morning, although I don't know if that's your normal time, but it is a weekend. But you know, certainly appreciate all the time and thought you put into the presentation.
Thank you so much. It is truly a privilege and an honor. Thank you.
Oh, thank you. And to everyone that joined us here today, I can't tell you how delighted we are that you are here. We care about each and every one of you, that this is truly a family. And, you know, we are here for you. So please keep coming back, you know, either to our Zoom calls and we're also available one-on-one. But thank you everybody for being here. And we will have our normal patient and caregiver support call Wednesday at 6 p.m. Eastern.
Bye, everybody.
Thank you.
Have a
Thanks,
great
everybody.
weekend.
Bye.
Be well.
Bye.
Good to see everyone. See you later. Thank you.
Bye,
Thank
Ann.
you. Great to see you.